Thank you very much, and thank you for your patience. Today I'm going to give you a broad overview, current state of the art, along with a few probably anecdotes and a little lesson in epidemiological study methods here and there, on the epidemiology and natural history of hepatitis C and hepatitis C virus. I'm going to talk a little bit about the history of the discovery of both the disease and virus, the virus itself and its clinical characteristics, the general population characteristics of individuals who become infected, and how there have been changes over time in transmission patterns, the natural history and the role of the cofactors that are just now being appreciated, and the current and future morbidity and mortality, both in the United States and worldwide. So for those of you who may not have had, who don't have clinical experience, viral hepatitis itself is just a non-specific term for inflammation of the liver. Viral hepatitis is distinguished by the fact, and there are many different causes of hepatitis. Anything that can cause inflammation of your liver, environmental toxins, sort of anesthetics, prescribed medications, alcohol, anything that can inflame your liver can cause hepatitis. Viral hepatitis is distinguished by the fact that the target organ is the liver, and that's where the virus goes to replicate. Viruses go to replicate. The term viral hepatitis we probably should stop using because these viruses are very distinct from each other. The only commonality they have is the fact that they all replicate in the liver. We know of at least 5 unrelated viruses, and they are called A, B, C, D, E, but they were not discovered in that order. Hepatitis A virus and hepatitis E virus are transmitted by the fecal-oral route. They can result in death, but if you don't die, you have a self-limited disease with no chronic infection in general. There's a vaccine to prevent hepatitis A. The 3 blood-borne and sexually transmitted viruses are hepatitis B virus, hepatitis C virus, and hepatitis D virus. Obviously, today I'm focusing on C. But all 3 are transmitted by percutaneous or mucosal exposures to blood, and all 3 cause chronic infection and are major causes of cirrhosis and primary hepatocellular carcinoma worldwide. Until you've had a reporter call you on the phone and say, if infectious hepatitis, if hepatitis B virus, let me see it was discovered first, how come it wasn't called hepatitis A? Anybody know the answer? I didn't either. I had to look it up. I mean, people think of the weirdest questions. Who cares? You know, really. But I had to look it up. That's when I worked for CDC. I don't think I had to do that at UTMB. Anyway, but viral hepatitis has been known, or at least infectious hepatitis, serohepatitis, has probably been known since the time of the Hippocrates. And it wasn't until the earlier in the 20th century, well, actually pre-World War II, that studies demonstrated there were two kinds with different incubation periods. Short incubation, which they referred to as infectious hepatitis because they thought it spread so rapidly from person to person, and viral and serum hepatitis, which they associated with contaminated blood. And since infectious hepatitis was the clinical entity first discovered, that's why it got the letter A. There it is. And hepatitis B, but the virus for hepatitis A was not discovered until the 70s, whereas the virus for hepatitis B was identified the antigen associated with this virus was discovered in 1965, or reported. And in fact, Barry Blumberg, the person who reported it, received a Nobel Prize for it. I don't want to, anyway. Interestingly, C was not the next virus discovered. C, however, was the next clinical entity discovered as a disease distinct from A and B, causing post-transfusion hepatitis of a longer, slightly longer incubation period than hepatitis B. And once they had hepatitis B testing, they realized that they had all these other cases of hepatitis from transfusion recipients, which they assumed could not be A because it had a long incubation period and it was transmitted by blood. Of course, we now know you can get hepatitis A that way too, but that's not here nor there. In the meantime, they discovered hepatitis D and E, but they kept preserving C. So that virus was eventually discovered. It was the last one of those five. The clinical features of hepatitis, or inflammation of the liver, are the same regardless of what causes it. And very common features are fatigue and malaise and loss of appetite, nausea and vomiting, fever. And then more hallmarks feature is obviously jaundice, yellowing of the eyes and skin, light stools, dark urine, abdominal pain, and hepatomegaly. Less common, diarrhea, arthralgias, and rash are more common with hepatitis B than any other chronics. But these tend to be uncommon features. So unfortunately, someone comes who has symptoms, unless their eyes are yellow, they come in and they don't feel well, basically. And in the old days, there was another hallmark sign, loss of taste for cigarettes. You don't put that up anymore. So this actually, infection was, or disease was described extremely well even before the virus was discovered. It was first identified as a clinical entity, non-A, non-B hepatitis, in transfused patients in the late 1960s by investigators at the NIH and others. Most risk factors that we now know today associated with acquiring HCV were identified before 1990 from cohort and case control studies of acute disease that were diagnosed by exclusion using a very rigorous case definition of people who had abrupt onset of viral hepatitis with high liver enzymes and could be easily distinguished from sort of chronic hepatitis. The risk factors that were identified were receiving whole blood transfusions or clotting factors, injecting illegal drugs, being a chronic hemodialysis patient, working in a healthcare setting and having frequent contact with blood and needles, transmission from mother to child, as well as between sex partners. We also knew that there was a high rate of chronic infection, even though we couldn't test for it. And the reason we knew that is not only was there the persistence of abnormal ALTs or liver enzymes in cohorts of people with non-A, non-B hepatitis who were followed over time, but also if all these people were getting infected from transfusions, then obviously there had to be some level of chronic infection in the population in people who otherwise were well. Then HCV was reported in 1989. It was discovered by recombinant DNA technology, cloning. It was determined to be an RNA flavivirus, and they created its own little, group, Hepativirus, or that's what I say, Hepativirus.
Yes, that's right.
I've heard it pronounced other ways. Anyway, it is, as I said, a clinical entity. Was shown to be responsible for most, but not all, transfusion-associated hepatitis that wasn't due to hepatitis B. It was also shown to be associated with most community-acquired non-A, non-B hepatitis due to other modes of exposure, mostly bloodborne, but also sexual. No vaccine has been developed, nor do most of us anticipate one in the near or far future. You know better than I, this is an RNA virus. Mutations occur during viral replication, creating substantial heterogeneity or quasi-species, which are similar but different from each other, even within the same individual, and it appears the host response is ineffective in neutralizing this entire population of viruses. So after discovery, there's an extra slide there, sorry. After discovery, so by 1990, we had a serologic test. By 1992, we had crude PCR, and which of course, nucleic acid testing, which had got better, obviously, as time went on, as did the serologic test for antibody. But that is all we have today. Serologic test for an antibody that does not distinguish between new or chronic infection, and a test for the, both the detection and the presence and titer of virus. Clinical symptoms of acute disease occur in less than 20%, but chronic infection develops in 60 to 85%, and in my opinion, is not related to whether or not someone has clinical disease at onset. Others might argue. Overall, among those with chronic infection, an average of 70% will develop some form of chronic hepatitis, chronic inflammation of the liver. Cirrhosis and liver cancer develop in a broad range, depending on a number of factors, which I'll discuss, between 5 and 20%, with mortality among those with cirrhosis and liver cancer 5% per year, well higher for liver cancer. Cirrhosis 5% per year. It is also, as Mike said, Dr. Gale said, the most common indication for liver transplant in the United States. So, where did it come from? You know, we always talk about hepatitis B and how, you know, it was described at the time of Hippocrates, so where's hepatitis C been? Where's this virus been? Why now? Why not before? Well, I'm not going to talk about the molecular clock because I have much more interesting things to talk about as far as the epidemiology. But I want to give you my, why I think it emerged. So it's been there for, I believe, centuries. But it emerged in the 20th century. So in fact, the pandemic, as referred to, is actually a product of the 20th century. And the reason is because this is primarily a bloodborne virus. It is most efficiently transmitted by large or repeated exposures to contaminated blood, however that might occur. So how, when you think about advances in the ways in which we manage to have percutaneous exposures, particularly through medical care procedures, I only realized when I put this together that those are quite recent. So let's start with the I don't know if I call it the discovery of the hypodermic needle, which was invented by Sir Christopher Wren in 1660. Everyone knows who Sir Christopher Wren is. He's an architect, and he should have stuck with churches. Because the first person they tried this on died. So they waited a really, really long time, until 1834, before they tried another percutaneous procedure. This was a human-to-human blood transfusion in 1834. And just prior to that, they had tried animal transfusions, which turned out poorly, as did this particular event as well. Believe it or not, modern blood banking didn't start really until the 1930s in this country. As you probably remember, it was only in the early 20th century that blood groupings were discovered. So that you could get compatible blood, and 2, anticoagulants to preserve blood so that it could be used. This was probably some of the biggest advances occurred during World War I on the battlefield. Modern blood banking, as we know it, with blood banks and organizations, started in the late 1930s. But by 1950, less than 20% of patients who were hospitalized received IV therapy. I mean, I don't know about you, but when I saw this, I was actually surprised. I thought, you know, we had these therapies around a really long time. And remember, vaccines only started getting used at this time too. Vaccines were very rarely given in the 18th and 19th centuries. But between 1950 and now, or the end of the last century, therapeutic procedures became very common. And they became very common because we found ways to make it economical and safe. So commercial companies started producing intravenous solutions. There were single-use disposables, and of course, all of our vaccines. In addition, we found a way to make ourselves feel better. And we had, during the last half of the 20th century, an epidemic of injecting herpes. And that's why I believe HCV has appeared all over the world in the last half, has emerged in the last half of the 20th century. Now, the extent to which these different factors play a role differs by geographic region and country, and even within countries, as I'll show you. But during the past 15 to 20 years, we've made a lot of progress. We've determined the burden of infection and morbidity in the general population. We've eliminated transfusion-associated infections in countries that screen donors. We've documented a more than 80% decline in the incidence of acute hepatitis C in the community. We've characterized the epidemiology. We understand how it's transmitted. We know who's at risk. And we've attempted to implement, or at least we have plans for implementing community-based prevention. So we've also characterized the natural history of HCV infection, although I'm not sure we got the entire picture to date, mainly because it's difficult to predict what's going to happen to people in 40 or 50 years when those events haven't taken place yet. But when you look at the natural history of, when you read articles on the natural history of HCV infection, on progression and rapidity of, and the severity of disease in people who are chronically infected, you have to take into account who was being studied and at what stage they were identified, because that changes the natural history. It changes the results. It affects the results, and it affects your conclusions about how severe the disease is. So, if we look at the onset of infection, which could be asymptomatic, and the worst endpoint, and here I'm using cirrhosis, most people get identified when they're diagnosed by referring to, by a specialist, hepatologist, because they're symptomatic, etc. And so the specialist will say, gee, there's a really high proportion of people with hepatitis who have severe disease, 30 to 50%. That's because that's what this person sees. However, you'll see a broader spectrum of disease severity if, in fact, you go to primary care practices who see milder cases but may not refer them, particularly in the days before therapy was as, and I use this term loosely, good as it is now, or before there was any therapy available. So a lot of physicians would follow their own patients, tell them not to worry about it because they really didn't know what the implications were, and therefore the specialist doesn't see the more severe cases. In that instance, they might say, gee, hepatitis C isn't that bad, only about 20% of people with hepatitis C develop cirrhosis. But let's say you managed to have a cohort of individuals who were all infected around the same time, and you followed them forward, regardless of whether or not they had symptoms, and regardless of what their outcome was, or whether they sought medical care, or whether, no matter what happened to them. In that case, money never can come to medical attention, either because they don't go see doctors, they don't have health insurance, or because they feel perfectly well. And many of them may resolve their infection naturally, as we now know. In that instance, you'll see a much milder or less severe disease, in the sense that a much lower proportion, 5 to 15%, develop cirrhosis. And that's actually the true rate of progression. in people who get infected with HCV. So this just demonstrates the natural history as reported in patients referred for medical care who were estimated to be about 20 years out after they were infected. And as you can see, the yellow represents chronic hepatitis, the green cirrhosis, and the pink primary hepatocellular carcinoma. So in this instance, you'll see that in 2 of the studies, 40% of the patients had chronic hepatitis. Anywhere from 40 to 50% had cirrhosis, and anywhere from 0 to 25% developed primary hepatocellular carcinoma. In one study, it was suggested that the route of infection was related to the severity of the outcome, but but cohort studies do not bear that out. This is a referral bias. You don't know where everyone else is who had those exposures and got hepatitis C and didn't happen to be referred to that medical practice, or any medical care for that matter. Plus, people with transfusion-associated hepatitis tend to be older, so there's a lot of issues. But this is a cross-section of a referral population, which they saw a lot of severe disease. In contrast, these are studies that these are studies that looked at individuals from time of infection, 20 years out, and stratified them by the age at which they got infected. So, in this case, red represents chronic infection, yellow, actually chronic hepatitis or disease, and green, cirrhosis. And there are 3 sets of studies. Those done where the individuals were exposed as young children, studies done among individuals exposed during their 20s, and studies done among individuals who were older than 45. And all of them were followed for the same amount of time, about 20 years. And as you can see, the younger you are, the less likely you're going to develop severe disease. You're still going to get chronically infected, fairly high rate of 60%, a little lower than we usually say for the average. But the rate of chronic hepatitis is only about 10%, and cirrhosis even lower. So this is much different from the group over 45, who actually form the bulk of the individuals from whom a lot of the conclusions were made about natural history. So this is just a little lesson on how to look at the literature when reading it and evaluate it for, how much it can tell you. We've also discovered, besides age and infection, we've discovered other cofactors that affect the natural history of hepatitis C, and particularly with respect to progression. So being older, as I mentioned, being immune suppressed, co-infection with HIV or HBV, metabolic syndrome, like hypertension, high triglycerides, etc. Heavy alcohol intake, diabetes, obesity, being a man. Can't do anything. Well, could do something about that, I suppose, but probably wouldn't change the risk. And some people have suggested genotype, and that's, of all these things on the list, that's the least well documented. Unfortunately, these cofactors or comorbidities are quite common in the population, and they themselves have been shown to cause liver cancer, cirrhosis and liver cancer, even in individuals who don't have hepatitis C. So you can see that they're actually quite common, and which poses an issue for individuals who are at high risk for both hepatitis C and also have a high prevalence of these conditions. We look at the mortality rate from hepatitis C from 1995 to 2004. One of the striking features is the fact that the highest mortality rate in the early half of the 21st century shifted to a younger age group, those 45 to 54, because they have the highest prevalence of hepatitis C. and they've been infected the longest, essentially. The second highest group is the 55 to 64-year age group. Again, crossing the oldest age group, which in the earlier years had the highest mortality rate. So this is a great concern. This means young people of middle age who are either still working or trying to take, enjoy their retirement are now at the highest risk of dying from hepatitis C. This is a new model that we just finished, which estimates the future HCV-related disease burden. As I'm going to show you later, the prevalence of hepatitis, of HCV infection, has already peaked in the United States, and now eventually it will start to go down. The problem is that we have not yet seen the peak of people with the complications they're going to have from their hepatitis C, because that occurs 20, 30, 40 years after infection. And so therefore we expect that while the peak incidence of disease, as I'm going to show you, was in the 70s and 80s, the peak rate of cirrhosis in these individuals, in red for example, will not reach its peak until 2020 perhaps, or 2025. Therefore, the burden and the healthcare costs and the consequences, the broad consequences that we expect to see, we will be seeing for, assuming no treatment, adequate treatment, for another 20 years. The same models have predicted the same kinds of curves in other countries. So that in fact, they're going to see the peak of their disease burden, later, even though the incidence is going down and their prevalence has already peaked. These are in countries that have a similar epidemiology to us. Currently, viral hepatitis worldwide, HCV-related end-stage liver disease deaths, total about 366,000, with a few, with cirrhosis slightly higher than deaths from liver cancer. So let's look at the United States. Currently in the and we'll look at both new infections as well as sort of cumulative prevalence. In the United States, the new infections per year peaked in the late 80s at 242,000 per year. I realize most of you weren't born yet, but that's when the true epidemic occurred. In 2006, it's dropped to 20,000, and I'll show you why. Deaths from acute liver failure are rare, but 4 million people have been infected at some point in their life currently living here in the United States. And that could be even as high as 5 million, if you look at the 95% confidence interval. And this is based on the National Health and Nutrition Examination Survey, which is a representative sample of the U.S. population, non-institutionalized civilians, non-Hispanic whites, non-Hispanic blacks, and Mexican Americans. 3 million, or as much as 3 to 4 million, are chronically infected. We expect that 40 to 60% of them will develop HCV-related chronic liver disease, and deaths from this are occurring at a rate of 8 to 10,000 per year. Risk factors associated with acquiring infection, as I mentioned, the most efficient transmission of this virus is by or by large or repeated direct percutaneous exposures to infectious blood, as would occur from transfusions or transplants from infectious donors, or ongoing injecting drug use. Less efficient are small percutaneous exposures to blood, very sporadic, such as might occur with needle sticks in the occupational setting. Less efficient still are really mucosal exposures to blood that occur through birth to an infected mother, having an infected sex partner, or having multiple sex partners, which is just means that your chances of having sex with an infected partner increases, the number of partners you have increases. These were all risk factors that were found during the height of the epidemic. So the studies that identified these risk factors were done around here, when there were lots of cases for us to look at. Since 1990, there's been a huge decline, more than 80% decline in the incidence of new HCV infections. The primary reason for this is a decline in cases among IDUs. The decline in transfusion-associated hepatitis, which in and of itself looks dramatic, actually had very little impact on the overall epidemic because it accounted for a small percentage of cases to begin with, only as many as 20% during its highest incidence. So injection drug use has always been a major risk factor here. But in spite of this decrease in incidence, as you notice, the prevalence, this is the cumulative number of people ever infected currently alive, has just peaked now at about 2% overall among the population I just described, 6 years of age and older. Among adults, it's higher, and depending on age, race, and ethnicity, it's even higher. And I'll hopefully show you that. And again, as I mentioned, those who are infected for 20 or more years, when complications are most likely to occur, are just now reaching that stage. This just shows you what happened with post-transfusion hepatitis, with the most, probably the most effective measure ever introduced, other than screening, was going to an all-volunteer blood donor system in the United States. Shortly thereafter, HBsAg screening for HPV was introduced, and when they got rid of it, and that's when they realized that most of the post-transfusion hepatitis had never been hepatitis B, but something else, which they called non-A/non-B hepatitis. And even as hepatitis B continued to decline, as testing got better, the rate of non-A/non-B hepatitis stayed the same until changes in the donor population were made as a result of HIV, which got rid of a lot of drug users who were previous to that donating. Surrogate markers for hepatitis C, like elevated liver enzymes or anti-core, and then finally anti-HCV testing. This is weird. And RNA. Oh, and RNA. So, injecting drug use, the biggest risk factor for HCV, accounts for most infections in Western countries, particularly in persons less than 50 years old. Now, in the 80s, when they first started doing studies looking at injecting drug users, they found 80% of them had been infected within a year of starting drug use, of starting injecting, or their reported year of starting injecting. That cumulative infection rate has slowed to 30%, which means that we have some time to intervene if we could. But the incidence remains high in new users. These are the kids, you know, between the ages of 13 and 20 and 18 who are just starting their drug use. And they still have an annual rate of 15 to 20%. So they get infected at an annual rate of 15 to 20% with HCV. And this tends to be associated with sharing cookers and cotton and their other drug preparation equipment independent of needles and syringes. So even if they used a needle exchange program routinely, they could still get infected. And most new users tend to inject in their early period with older users. And older users are more likely to be infected, and they teach them how to inject, and you know, likely there's some sharing. So while sterile needles and syringes or clean needles and syringes are the message for prevention of HIV, it is insufficient for prevention of HCV. Now, one of the things that are included in prevention messages is you are at risk of hepatitis C even if you injected only once. And baby boomers, who are now the CEOs of and taking all those bonuses or getting fired or whatever, might have used some recreational drugs when they were in college 30 or 40 years ago, and they might be reluctant to admit it or not even remember it or think it applies to them. And while the statement, if you ever injected only once, we would say it made people at risk, we actually never had any data to prove it until now. This was a study done among college and university students of a very low frequency of injecting drug use to begin with. But among those, as you can see, those who never injected, which was 98% of the population, had a prevalence of 0.5%, which is normal for the general population. If they ever injected, which was 2% of the population, by the way, the denominator here was about 6,000, then 23% were positive for HCV. So that's usually the kind of thing you see. But if they'd injected once or twice, they said, we asked them how frequently they injected. So they got to say, once or twice, daily, regularly, or sporadically, meaning it was on an ongoing basis, but at sporadic intervals. Once or twice, they still had an increased prevalence of 9%. Daily, regularly, or sporadically didn't really matter. There was no differences between those three, and 29% of them were infected. So the only once seems to apply as far as increased risk is concerned. Now, there's also a risk through occupational transmission, although it's inefficient. The incidence it ranges from less than 0.5% to 2% following a needle stick from an HCV positive source. There have been some case reports of transmission from blood splashes to the eye and one from exposure to non-intact skin. When we have these single kinds of exposures, no epidemiology in the world is going to prove that they occurred because you only have two people. The source and the individual got infected. So you can't do statistics on two people, and it might make common sense, it might be temporally associated, but you can't prove it. But you can use molecular techniques to show that the virus, isolates in the two individuals are either identical in the hypervariable region or highly related, depending on how far along in their infection you test them. In addition, the other reason we say this is inefficient is because the prevalence of HCV among healthcare workers is only 1 to 2%. Which is actually lower than adults in the general population. And it's 10 times lower than it was for HBV infection before vaccine became available. And this has not changed over time. It was the same before universal precautions as it is now. So while being stuck with the needle and working in a healthcare occupation you might expect by a needle is a risk for hepatitis C, the group as a whole is not a risk group. Therefore, it would not be very efficient to screen them as a whole for hepatitis C, only after an exposure. Birth to an infected mother is also a risk factor for HCV. It appears to only occur from women who are HCV RNA positive at the time of delivery. The average rate of infection is 4 to 6%, but it's higher if the woman is co-infected with HIV. Unfortunately, while it might make sense that it should be associated with virus titer, it's inconsistent between the studies. And so it's very unclear. And the threshold for transmission, because the threshold for transmission is inconsistent, you can't say, well, you have 10 to the 6 or 10 to the 7, then you're going to transmit, but if you have 10 to the 3 or 10 to the 5, you won't. Risk factors that have been consistently identified include internal fetal scalp monitoring and prolonged rupture of membranes before delivery, which might suggest that rather than emergency C-section, elective C-section would be good in someone who had early rupture of membranes, but it's not possible probably to prove that. There is no association, however, in general with delivery method or with breastfeeding. And this is similar to what we see for hepatitis B, different from HIV. The HIV and HCV are biologically much more different than the two hepatitis viruses. This just shows the data for the statement I just made, so I'm just going to keep going. Now, just as it's important to know what exposures are associated with acquiring hepatitis C, it's important to know what exposures, potential exposures, are not associated with acquiring hepatitis C. And in studies done in the 80s, in the late 70s and 80s, when the incidence was high, and there are a lot of people with the study, we found this list these different types of potential exposures not to be higher among individuals who had just gotten disease. So during the incubation period, in the 6 months prior to onset of disease, than in individual controls who were healthy. And so as you can see, there's no association with medical prayer procedures, dental work, being in a healthcare occupation but not having any blood contact, having ears pierced, getting tattooed, receiving acupuncture, being in prison or jail, traveling overseas, or serving in the military. Some of this may be contrary to what you hear or read on the website, but I'm right and they're wrong. The problem is, there is such a thing, the best studies, case control and prospective studies of new disease where you know the temporal sequence of events. You know that the exposure rate you're asking about took place prior to the infection event. Doesn't identify rare events. So if the event is really rare and only occurs infrequently, you will not identify it in the best epidemiological studies because you'll never have a sample size large enough. And these rare events tend to cluster. They cause outbreaks, and that's how they get recognized. But if you do a study in the population as a whole, it won't look any different. And healthcare-related procedures is one of those, in which we've had quite a bit. In the last 10 years, it's been substantial, patient-to-patient transmission of HCV. It's very difficult to detect. We have the health departments now have a whole new algorithm for looking at this. It's been identified in just about every setting in which healthcare is delivered. And it's mostly due to unsafe injection practices. And when I say I'm talking about the United States, and I'm talking about the reuse of needles and syringes to contaminate multi-dose vials that are subsequently used on other patients. That's what I'm talking about. Or even the needle and syringe is reused on other patients as well. So this is happening in many hospitals and outpatient settings throughout the country and throughout Western Europe, as well as other developed countries. And there are programs now to try and re-educate healthcare professionals about the need for aseptic technique when preparing and giving injections. It's the same as a surgical procedure. You're entering the individual's body, and anything that enters the individual's body should be sterile. And the other rare event that's recently been identified has been clusters of infections among HIV-positive men who have sex with men who do not inject drugs. That appears to be due to higher sexual activities. And sexual transmission is one of the biggest debates around hepatitis C, or at least it was until men who have sex with men finally, started transmitting. But for some reason, I seem to have deleted the 3 copies of that, all 3 copies of the slide. I cut and pasted in there. But there was evidence for sexual transmission of HCV among heterosexuals from the studies done when the incidence was very high. It's been very difficult to show since the incidence has declined, which is when a lot of studies have been done and published. So most people only know about those studies. They don't know about the studies that were done when the incidence was high. And as I was talking about yesterday, if you have an inefficient route of transmission, but the behavior is very common, then you increase the probability that you can get infected by an inefficient route of transmission. And sex is an extremely common behavior. It's more common than getting a blood transfusion. Certainly more common than getting a blood transfusion from an infected donor. And more than 80% of adults in the general population have had multiple partners. And this was true in 1980 and 1990, not now necessarily 2009. So, there was a lot of sex going on, especially in the 60s, 70s, and 80s. And it's possible also that people are more likely to transmit during different phases of infection. So if, let's say, you're more infectious during the acute acute phase of your infection, when you've got a lot of virus and very little antibody or none, hasn't developed yet, it's possibly more likely to transmit then than when you're chronically infected. And which would explain why long-term partners have very low rates of HCV, whereas we saw high rates of potential sexual transmission among people with the partners of people with acute hepatitis C during the epidemic period. Now, I can argue both sides. Why, during the epidemic period, didn't we see transmission between men who have sex with men, who are the hallmark group for the sexual transmission of a blood-borne virus? And we didn't see it. And this was before the measures were taken to prevent transmission of HIV by safer sexual behaviors. So now all of a sudden we're seeing it in HIV-positive men who have sex with men, and I can't tell you why, because I don't know. Now, the other interesting aspect of the epidemic of HCV, and one that when people refer to the epidemic or pandemic, this is what they're referring to, and that is the prevalence, the cumulative infection rate of everyone who's currently alive today. And we've measured this twice, and we'll continue to measure it. We measured it at, I'll say 1990 and then again in 2000. Those were the midpoints of the study years in the general population among, as I said, whites, non-Hispanic whites, non-Hispanic blacks, and Mexican Americans, which are the three groups that have large enough populations in the United States to sample statistically so they're representative of those populations by age and gender. And the prevalence essentially did not change between these two time periods, which is what we expected. Since the incidence was going down, there was no reason to expect that the prevalence would go up because more infections weren't accumulating. And we're doing this by serology and by RNA, so we're not, people don't have to be sick to be identified. And the one thing that did occur, however, note, is the shift in the peak from 30 to 39-year age group to the 40 to 49-year age group. We also predicted that, makes sense. New infections aren't occurring at a very common rate. This is the same population. They got older by 10 years, so did the peak. Doesn't explain this stuff. Check this out. And this is actually only showed you the data from 2000. But it turns out that blacks who have the highest rate prevalence, or black men between the ages of 40 and 49, have the highest prevalence of infection. Which was also true in 1990. They did not move a decade. They only moved 5 years. So what happened was, in 1990, the black men most likely to be infected were like 40. So when we measured it again in 2000, they hadn't moved into their next decade of life. They'd only moved into the latter half of the same decade. That was not true for whites, who did move from the 30 to 39 to the 40 to 49. That's in the yellow. And then look at Hispanics, Mexican Americans. This is largely ignored by everyone when they talk about prevalence. But in both 1990 and 2000, Mexican American men had a peak prevalence in their 50s. And it increased from 6% in 2000 to 10%, 6% in 1990 to 10% in 2000. And, I don't think I have time to show the data, but Hispanics have the highest rate of liver cancer in the United States, second only to Southeast Asian immigrants. And Southeast Asian immigrants have liver cancer because they have chronic hepatitis B. Hispanics have liver cancer probably because they have chronic hepatitis C, and they're younger. They're getting it in their 60s and 70s, not in their 80s and 90s. So age is moving to younger individuals, and Hispanics are at a higher risk even than blacks. Okay. Now, HCV has been divided into for the purposes of this discussion, 6 major genotypes, which describe the degree to which they are different or the same. And so the largest degree of difference is classified as a genotype. It gets a little smaller. Within a genotype, there's subtypes. So the genotypes are 1, 2, and 3, 4, 5, and 6, actually. And the subtypes, there are over 100. And 1A, 1B, 2A, 2B, 2C, 3A, etc. And they have a little less diversity. And then there's the relatedness of viruses where they're completely identical, either within the same person or between 2 people who have transmitted to each other. But as I mentioned earlier, these viruses produce mutations as they replicate, and they have extraordinarily high rates of replication per day. So they're constant. It's say
10 to 12.
10 to 12 per day. That can create a lot of quasi-species over time. In the U.S. population, 70% of, in the U.S. population, the distribution of genotypes has not changed over time. 70% of the population is infected with genotype 1, and that has not changed. This is very different than what's going on in Europe, Western Europe, where it has changed. It's gone from genotype 1 to 3. And it doesn't differ in the U.S. by risk factor. So individuals who've been transfused as their risk factor and are in their 60s or 70s now have genotype 1, as do injecting drug users who are 25. Genotype 2 is our next most common, and then genotype 3. Genotype 6 has only been found to date in individuals who have immigrated here from Southeast Asia, where genotype 6 predominates. Virtually everyone is being born in the U.S. is actually associated with HCV. And as this shows, most of the individuals were U.S. born, including those with genotype 4, all of which were seen in blacks, but all of them were U.S. born. And genotype 4 is the most common genotype in South Africa. And, in Africa, northern and southern. And as I mentioned, all of our genotype 6 were in individuals who were born in Asia. So it's interesting. If ever the U.S. was described as homogeneous, it would be with respect to HCV genotype. That's the only time I could ever use that term in this country. Now let's look, I described to you how we identify the risk factors associated with acquiring HCV. So now when we look at people at one point in time who've been infected for who knows how long, you can only describe how often you find those risk factors, as well as what their demographics are. And that's what we do when we look at this NHANES population, the general population. So we can see how common it is in the U.S. population. I mentioned in individuals 6 and over, the average is 2%. But in adults, it's much higher, depending on race and ethnicity. Interestingly, among those aged 20 to 59, which is the only individuals they ask sensitive risk factors to, which obviously they're going to have to change because those of us who reached 60 were in the, experimental group when we were younger. So if you don't ask us those questions, you're not going to be getting accurate histories. Anyway, the point here is note that Mexican Americans had a 3-fold higher rate of HCV infection just by being Mexican American, independent of any other behavior or risk factor. And I bring that out because it suggests to me that we're missing something. There's something we're not measuring in that population that's different than non-Hispanics. They report transfusions and drug use the same frequency as non-Hispanics, but there's something else going on that we don't know. Also note that being born outside of the United States is protected. So, and this primarily applies to Mexican Americans. because it's Mexican Americans born in the U.S. who have the highest rate of hepatitis C among Mexican Americans, not those who were born in Mexico, and being poor. As far as exposures, having a blood transfusion before donor screening, injection drug use, which has the highest risk associated with it, almost 150-fold higher than never using drugs, and having 20 or more lifetime sex partners. That 20 is not a magic number. It changes depending on who you measure. Sometimes it's 5, sometimes it's 10, sometimes it's 20. It really depends on the population. But also know, oh, I didn't put it there. The 80%, I mentioned 80% of adults in the population had multiple partners, which means they had more than 2. Have had 2 or more. And a quarter of the adult population have had 10 or more. So, when we look at people who are getting newly infected now, most of them are getting newly infected because they've injected drugs in the incubation period. 20% of them all give a sexual history and no other risk factor. They deny injecting drugs, they deny needle sticks, they don't work in the healthcare field, etc. So that's the only risk factor they give. Either their partner is HCV positive or they have multiple partners. Where compared with those who we don't know when they, who got infection earlier, they're part of our cumulative prevalence. And in that case, injection drug use is still important. But in these individuals, a history of transfusion accounts for about 10%. Sexual activity in the absence of any other percutaneous risk factors reported still by 20%, which may seem inconsistent with the fact that it's very inefficient at transmission. But as I said, sex is more common than any of these other behaviors. Therefore, your chances of actually having sex with someone who could transmit to you if you're having multiple partners goes up. So, what's important about defining the characteristics of the population by epidemiological studies is that you know who you want to target for prevention services. And most HCV, while you may read on the web or on posters a laundry list of factors that put you at risk of hepatitis C and for which people, whoever wrote the poster, think you should be tested. In fact, most HCV positives can be identified based on 2 to 3 major characteristics, which is history of transfusion, if they're old enough, and injecting drug use, and maybe one other depending on the population. And these laundry lists of risk factors distract attention from those that really should be used for testing. Generic risks demand their own messages, regardless of risk. And what I mean by generic risks are things like tattooing and body piercing, or even snorting cocaine. One, you're not supposed to use illegal drugs. So the prevention message is there. You don't need to tell someone they're going to get hepatitis C. They're not supposed to be using them. And as far as tattoos and body piercing are concerned, if something's going to pierce your body, you better make sure it's sterile. Even if it doesn't matter whether it transmits hepatitis C or HIV or hepatitis B, but in fact, actually, if you read the list of bacterial infections that you can get from a tattoo, it's frightening. So when the public health message is not that you should screen based on that, but rather that if you're going to get one, you should make sure that the equipment is sterile and that the artist knows what he or she is doing. Unfortunately, less than half of HCV-infected patients have been identified in the United States. And we put the burden on healthcare settings and healthcare professionals to identify them based on risk histories, and that's never going to happen. So we need to find other ways. Otherwise, we're never going to be able to identify these people and treat them. Now, in worldwide, 2 minutes, or maybe not. Worldwide, the distribution of risk factors is a little bit different. So in the Western world, drug use and transfusions before donor screening. In developing countries or resource-poor countries, if they don't screen their blood, then that's still a risk factor. But unsafe therapeutic injections, the reuse of disposables, Overuse of injections when oral medications would be just as good, or going to lay people to get your injections rather than a healthcare professional are all risk factors for HCV. And the global burden of hepatitis HCV infections attributable to contaminated healthcare injections is actually 2 million annually and 21 million for HPV. These are not due to immunizations or vaccines, because most vaccines, while being administered by injections, are part of the expanded program on immunizations delivered by WHO, and they also deliver the injection equipment with them. But rather, they're therapeutic injections. And as a result of inadequate supplies of sterile syringes, inadequate sterilization, administration by non-professionals at home, the household syringe and needle that everyone, in certain cultures, there's always a syringe and needle in the household, and the expectation that unless you get a shot when you're sick, you're not being treated. This is an example of the disinfection of disposable needles and syringes in a clinic in another country. This is hospital waste that's being sorted through by young kids so that they can sell the disposable needles and syringes they buy. So what are the current and future issues? Well, in the Western world where we can afford it, we need to identify infected people, and that is not being done effectively. Therapy regimens currently are less than ideal, especially those with genotype 1. And in the US, treatment is actually offered to a low percentage of HCV positives. So in most settings where they even offer it, particularly, I mean, if you look at, like, for example, the VA, which is sort of under a mandate to identify everyone who's HCV positive and offer them therapy, less than 10% of those who are actually identified end up being treated for a variety of reasons. We haven't fully appreciated the implications of multiple co-factors on liver disease and how that might impact on treatment. And we need to be constantly alert to changes in the epidemiology. And finally, we may develop wonderful therapies. I mean, there are, as you know, great advances in the ability to produce new therapeutics, even for hepatitis C. The good news is that they're very promising. But the bad news is they cost a lot. Some of them have side effects and contraindications. And how are we going to extend, if we do find the magic bullet, how are we going to extend the benefit to the vast number of persons who could benefit but can't afford it? It's a debate that's been going on for HIV for a very long time, partially being addressed by the PEPFAR initiative, but this is, you know, on the heels of that, and certainly the money being poured into HIV is, you know, for AIDS is not even, is outside, is in another, you know, universe compared with the amount of money that's attributed to HCV. So, or contributed to HCV research and implementation. So we have a lot of remaining challenges, particularly internationally, but also right here at home. And this actually has absolutely nothing to do with this. So